I said that the two eyes and the two ears play a very important role in balance. So gravity from below and light are important for balance. If we don't have balance, we will fall down and will be eaten up. Now skew is a writing reflex which has gone wrong. This is showing the graviceptive pathways from the vestibule up to the vestibular nuclei, crossing at the level of the sixth nerve nucleus and crossing to the opposite side, ascending in the MLF till the RIMLF, and INC is nearby, and third nerve and fourth nerve are there. So this is the pathway. Any lesion anywhere can give rise to a problem. Now this is showing the connections of the anterior, posterior and horizontal canals. As you know, the anterior canals are exciting the elevators, that is the superior rectus and the inferior oblique, and the posterior canals are exciting the depressors, and they are going to inhibit the opposite muscles. So anterior canal dominance will produce an elevation, and posterior canal dominance will produce an depressing effect. Now this, what I was saying, if there is a problem with the anterior canal pathway here, then what you will see is this, that the superior rectus is gone, this eye will depress because of the IR, this eye, the inferior oblique is gone, so this eye is going to intort because of the superior oblique overaction. So this eye is hyper and this eye is hypo, but this is incomplete ocular tilt reaction. This is not complete. Now if there is a posterior canal problem, you find that this eye is elevating because of the, sorry, this eye is this eye is extorting because of the inferior oblique overaction, and this eye will also be depressing. So if they are together, then there is more vertical, and one eye is intorting, the hyper eye will intort and the hypo eye will extort. So this is very important to keep in mind. If you are dealing with a superior oblique, the hyper eye is extorted, whereas in the ocular tilt reaction, the eye which is hyper is intorted and eye which is hypo is extorted. So you may have incomplete one, that there is only extortion or there is only intorsion. Quite often you have an extorsion, and so you can also have an incomplete one. This is showing in three planes it can happen. In ROL you have ocular tilt reaction. Here you have in pitch plane inferior oblique overaction, what we call as primary inferior oblique overaction or primary superior oblique overaction, and in yaw you have acute acquired competent esotropia, AAC, which can also happen in neurological disease. It is important to keep this in mind because you may have an ESO deviation, which you may think it is quite innocuous, and there could be a tumor sitting in the cerebellum, in the vermis in particular. So that has to be borne in mind. This is showing the ocular tilt reaction in ROL plane. There are three components. As I said, there is a vertical deviation as we are talking, and there is a conjugate torsion. One eye is extorting and other eye is intorting, and there is a head tilt to the same side. All these three components make it into an ocular tilt reaction, what we call as OTR. Now, etiologies can be, most common are these: brainstem stroke in our setting, tuberculomas, and tumor. Other things can be there, but most important are tuberculomas and stroke in our country. Now, other fellow travelers could be in internuclear ophthalmoplegia and pretectal syndrome. Now, the clinical features will be that there is a tilt in the subjective visual vertical, which patient is not aware, though there is a problem. There is a conjugate torsion and AHP, as we were saying, but these may again be asymptomatic. The vertical diplopia is often symptomatic. Head tilt test is usually negative, but can be positive. In these cases, there is no primary or secondary deviation, as we find in paratic strabismus. There is this could be comitant or incomitant, complete or incomplete, as we said, and there is no spread of comitance and no pattern strabismus. You don't find A and B patterns in these cases because the problem is elsewhere. Now, this is what is important to do is do a DMR, double Maddox rod, and look at the subjective torsion. You will find extorsion in one eye and intorsion in the other eye, because most of these conditions are acquired. So this is very important to look at this. And you also make them lie down and look at this, because in ocular tilt reaction, the subjective torsion and vertical deviation are supposed to disappear, whereas in the case of superior oblique palsy, there is no change. So if you find that there is disappearance or reduction in the vertical deviation and ocular torsion in the supine position, this points out towards an ocular tilt reaction very strongly. This is showing the conjugate torsion, that one eye is extorted and other eye is intorted. This is seen nowhere other than ocular tilt reaction, and we saw in that case also in the previous presentation that this was happening. The ocular, as I said, the head tilt test can be positive because one side of the vestibulo-ocular pathways are gone, so there is not going to be any effect. But if you tilt the head to the opposite side, this may come positive. So this can create confusion with the superior oblique palsies. This is showing an ocular tilt reaction. As there is this thing, INO here, you can see that eye is not adducting, there is an exotropia, and this eye is hyper. This was because of a lesion in the MLF, because of ischemic event. He had a cardiac problem. This you can see the conjugate torsion here. This is another patient who had a thalamic infarct, and it was a pretectal syndrome. You can see there is up gaze limitation, which is quite gross, and there is an exotropia, which can happen with pretectal syndromes. And this again you can see torsion, that this is intorted, this is extorted, this is will be right in ocular tilt reaction. This is showing after 6 months and 1 year, there is some change, some improvement. OTRs are supposed to recover, but there has been some change, but it has not totally recovered. This is showing the MRI. We don't have time to go into detail. This is another patient, very interesting. You can see exo in up gaze and ESO in down gaze, gross ESO and lot of exo. So this is happening. She has a bilateral superior oblique palsy and also has ocular tilt reaction. Both things are happening in this case, as we shall see later. You look at the torsion, you don't find this kind of thing in superior oblique palsy. This eye is showing gross in torsion, this is grossly extorted. And as we shall see later, this has, once the skew deviation has recovered after 6 months or 1 year, this eye which was intorted has extorted. So this can only happen in a situation where there has been recovery, and now you find bilateral extortion, which is pointing towards a bilateral superior oblique palsy. She had a pyrocytic astrocytoma in the cerebellar area, which was removed, but despite that, she had these issues, and this is differential diagnosis. As we said, you have to look at third nerve palsy, incompetent OTR, and inferior oblique palsy, and superior oblique palsy. It can create diagnostic problems with these conditions mostly. Of course, myasthenia gravis and all have to be kept in mind. Now, in pitch plane, you can have, suppose you have a problem in the midbrain, you can have horizontal gaze palsy, which can present with both eyes not abducting well, both sides. And if you go further, you find that there is bilateral intorsion or extorsion. Here you find that there is intorsion in this side, this is also intorted. So bilateral intorsion will happen, which will look like a superior oblique overaction, or bilateral extorsion, which will look like inferior oblique overaction. This is showing an MRI. You can see there is a large tuberculoma sitting there in the pons, which was causing this problem. Now this is an acute acquired complaint esotropia in a child who was about 10-year-old, complained of diplopia. You can see the abductions, the movements are perfect. There is no limitation of movement, so it doesn't look like 6-nerve palsy at all. This is showing the MRI of this child, which is having a lot of diffuse tuberculoma. So this was the cerebellar tuberculomas can cause acute acquired complaint esotropia, which can create issues. This is after some treatment with anti-tubercular treatment. It has recovered to some extent. It is not fully recovered, and ultimately it did recover, and it was lost to follow-up. I don't have those photographs at the moment. Now this is, again, you had torsion which was looking like conjugate torsion in this child. This has recovered a bit. This is another child with Dandy-Walker syndrome, acute acquired complaint esotropia. You find a large lesion in the cerebellum and in the fourth ventricle, and this is showing torsion. There is intorsion here and extorsion here. Thank you. So this is, excuse me, jinx the diagnosis of acquired strabismus. Look for this thing, skews in INOs, pretectal syndromes, and acute acquired complaint esotropias. Include subjective and objective torsion assessment in all these cases, and gaze and the supine position changes in torsion and vertical deviation, because this is the only way to distinguish a superior oblique palsy from these cases. Keep low threshold for suspicion and order neuroimaging. Wait for resolution, because a good number are going to resolve, and if they don't resolve, you have to do surgery. Usually the surgery has to be the recti surgery, because obliques don't help. Thank you. The next talk will be by Professor Vinita Singh. She will be talking about DVD.